Hello, PsyQ community, and welcome to today's presentation, Telepsychiatry, Implementation and Best Practices. Dr. Chip Meyer here from the Otsuka Field Medical Affairs team, and today we'll be speaking with Dr. Mehdi Qalbani, co-founder of Integrated Behavioral Health, LLC in New Orleans, Louisiana. This presentation was sponsored by Otsuka Pharmaceutical Development and Commercialization Incorporated, and the speaker is a paid consultant of OPDC. Before our presentation with Dr. Qalbani begins, let's take a moment to review our objectives. Today we'll understand mental health care access in America, review guidelines and considerations for implementing telepsychiatry, and discuss the future of telepsychiatry. Without further ado, I'll turn the presentation over to Dr. Qalbani.
Hello, Chip, and thank you for giving me the opportunity to talk about a method to improve access to psychiatric care. Before I begin, just a little bit about me. I'm a psychiatrist based in New Orleans, and my primary clinical work is as a member of assertive community treatment teams, both in person and via telemedicine. I also care for patients, again, both in person and via video, through a traditional private multidisciplinary group practice, which I co-founded and co-manage. Finally, I consult with telepsychiatry companies to help establish and refine their programs. But enough about me. My goal today, as Chip said, is to first establish that there is a need for improved access, which, if you're listening to this talk, you likely already know. Then to give an overview of things to consider when beginning your own telepsych practice, or when adding a new telepsychiatry service line to your organization. I'll also comment a bit on clinical aspects of care delivery, and finally discuss what some of the near future holds with respect to this medium. Let's establish that there is indeed an access problem to mental health care. In our everyday life, especially my everyday life, it seems access is a definite problem. It seems clear. See it on the news, we hear it among family and friends, and we ourselves may have had trouble finding quality, affordable, timely mental health services. As a practitioner, I'm keenly aware of my wait times, and patients also tell me how long it takes to get in to see someone. As a founder of the group practice, I also know how hard it is to recruit enough psychiatrists and caregivers to meet the demand. But in addition to the anecdotal evidence, let's look over some of the data points on this slide. Look at the top left, we know that 1 in 5 Americans are living with mental illness, and only 40% of them were able to access treatment. And that's only one visit. My usual practice is to see a patient at least once a month until some significant improvement has occurred, and then we space out our visit. So even the minimum is not happening. Then there's the workforce. We, psychiatrists, who have chosen to focus our careers on caring for those with mental illness, are aging and not being replaced in sufficient numbers. We are not equally located throughout the country either, leading to shortages in rural areas, and even in areas where we are enough in number, we as a group are often not on insurance panels, leading to care deficit areas in cities as well. 2 additional points on this slide. Last year's match, in which medical students choose their profession, showed that more people chose psychiatry as their specialty. Not enough to replace the aging population, but that is a hopeful sign. And then another kind of baseball style asterisk to this slide is we may actually have enough of a workforce, but for the reasons mentioned above, geography and insurance, we're not reaching all the patients that need care. Insurance reimbursement and approval of treatment is above my pay grade, but telepsychiatry can definitely make a dent into the geographic problem, both in rural settings where there simply aren't enough psychiatrists, to urban settings where access is limited by other barriers. Now that we've established that what many of us intuitively know and suggested that telemedicine in general and telepsychiatry in particular may help ease the issue of access, let's define 2 terms. The first is telemedicine. Telemedicine is a process of providing healthcare from a distance through technology, often using video conferencing. Telepsychiatry is a subset of telemedicine and can involve providing a range of services, including psychiatric evaluations, therapy, which can be individual, group, or family, patient education, and medication management. And on this slide, I wanted to point you to 2 valuable resources, the American Psychiatric Association and the American Telemedicine Association. After this overview, hopefully you can go to these websites and get a deeper dive into the scope of practice. You'll also see themes emerging on this slide and the following slides that are grouped here. For example, you can see there are administrative concerns to go over, technical considerations to, consider, and clinical consideration to ensure that the patient is getting the standard of care treatment with specific attention pertinent to this means of treatment. On the APA's website, you can get further knowledge on the history of telemedicine, which just shows that this is not a new modality, but a well-established method of treatment that has adapted to increasing technological capabilities. You can get more information on training considerations specific to this practice, general legal requirements to be aware of, reimbursement issues, once again, the technical part, and then the practice itself of telepsychiatry. Let's go over some of the more specific administrative tasks you want to have on your checklist. In the top left, licensure. Generally, you should be licensed in the state where your patient is located. Though this seems simple and straightforward, it can get complicated very quickly when considering the populations you actually care for. In our practice, we have kids who grow, as kids do, and go away to college, or college students who go away to graduate school. We have people who work in film and go away to be on set and don't want to interrupt treatment. And living in New Orleans, we have musicians who go on tour and want to continue their care. So we try to do our best. We see patients when they're here as often as possible, but remain available when they are away. The Interstate Licensure Compact can help here in that you can ease the application process to other states if you are primarily based in a state that is a member of the compact. Unfortunately for me, Louisiana is not one of the 20 states participating. So to summarize, get your state to join the compact, and not to be sanctimonious, but practice as you always would. Do what you believe to be best for your patient and their individual circumstance. And likely not coincidentally, we'll move on to malpractice. Similarly, have a good relationship with your malpractice carrier. We're lucky to have a contact in our practice that is very responsive to our needs. If you partner with a national group, they will often provide you malpractice coverage. Just make sure you read the details to give yourself peace of mind as it relates to telepsychiatry. In terms of billing and reimbursement, this seems to be getting better. It used to be quite challenging to get services approved. We had to add GT modifiers to billing codes. We had to beg for approval, but now it seems the payers are generally on board with telepsychiatry being a viable, effective way of delivering care. We've gotten to work with the insurance companies, asked what kind of pain points they're having, and then proposing telemedicine when appropriate as a solution. And they seem to be adopting it with more vigor. It also helps that parity laws have been passed in many states. We also try to provide feedback from our patients and how much they appreciate the care and flexibility that telemedicine offers. At this point, it'll also be useful to implement a psychometric program, which you'll see on a later slide, within your telepsychiatry practice, or even your general practice, to show your patient the course of their treatment, for yourself as a provider to get a number to your treatment. And of course, I'm not saying that a single number can summarize the entirety of treatment, but I have personally found it rewarding to see patients improve when using psychometrics, and it has given me pause and adjusted my treatment interventions when the patient is not improving. It is a useful additional data point in caring for your patient. Practice obligations. The golden rule here is practice as you would in person, but there are a few extra things you have to consider. For example, prescribing, the Ryan-Haight Act. This act required an initial in-person visit and a visit every 24 months in order to prescribe controlled substances via telepsychiatry. There were several exceptions to the rule, but overall it was still quite limiting. And more recently, there is the Support for Patients and Communities Act, or more fully, the Substance Use Disorder Prevention that promotes opioid recovery and treatment for patients and Communities Act. All of those words will basically give us guidance regarding the rules the DEA will be using to allow us to prescribe controlled substances. And then the issue of informed consent. Just like you would get informed consent in person, you'll need to have informed consent for telepsychiatry visits. But there are some additional caveats to add. I try to set expectations and let my patients know that I may miss something that I would see in person or smell in person. The smell of alcohol or nicotine. Depending on the lighting in the patient's face, I may miss a fine tremor or a side effect from a medication. There's always a potential for technological failure, and so we always tell the patient what we do in backup, and in my case, that's using the telephone. But that may impact care, switching mediums when you're within a session. The things that they should continue to expect. They should expect the same level of confidentiality and privacy, and that'll be ensured through HIPAA-compliant video, and that the patient can withdraw consent or can withdraw from treatment, and that the provider can decide to withdraw from telepsychiatry service and ask for an in-person visit or refer to a local provider. The patient also has additional responsibilities. The patient will not record the session. They will let the psychiatrist know if anyone else can hear the session. The patient will attempt to have privacy akin to an in-person visit, and they'll inform the psychiatrist that they do not feel the televisits are achieving their goals and alternatives will be given. Just like in person, I want my patients to tell me if what I'm doing is helping or not. And finally, some other considerations just on this slide. Always know how to reach emergency services in the place your patient is located. And I always also like to have a patient support person or someone that can be contacted immediately during the session should that be needed. Technology. This is just so much easier now. You can start your practice just on your own if you'd want to. So let's start with HIPAA compliant video conferencing. These are essentially off the shelf and you can plug and play. They have integrations with your calendar apps. You can send invitations to patients. You can direct message links to patients. This is just really not that difficult to do with some technological savvy. I guess I shouldn't say that specifically, but it's not as hard as it used to be. Broadband internet, this is geographically determined, and 5 megabits is usually pretty doable. For example, one of my ACT teams, we often treat patients that are without homes, and our iPad with a hotspot most of the time, not all the time, but most of the time, allows a good enough internet connection for video. And when it doesn't, again, we have phone backup, which is number 4 over here, just jumping back to the backup plan. Usually the phone will work, and one session I remember in particular, I actually did a typed out chat with the patient who was unwilling or unable to speak, but would allow me to interact with him via video, and his therapist then filled me in afterwards. So again, allows a little bit more flexibility that you may not have in person. And then just to be thorough, the security of the PHI, secure your data, and if you use an EMR, it should meet this standard. And then integrating video conferencing with other technologies. Just remember that video is just one tool among many. We have patient portals, secure messaging, automated reminders. Make sure your tech is up to date. Make sure you add patches and update your software. And then finally, be cautious of using social media and always maintain professionalism. Good for telepsychiatry, just as it is good in regular life. Website manner. This is how you interact with your patients over video. It's similar to your clinical manner, but for me at least, it's just amped up a bit. I noticed in one of my recorded sessions when I practiced telepsychiatry that I appeared a little flat on video and I was not as animated as at least I think of myself in regular life. So I made sure I just speak a bit more expansively, a bit louder, and oftentimes a bit slower. I'm not trying to act or to be a caricature, but I just feel more connected with my patients and adding to my normal level of expression. And it seems that the patients have also given me similar feedback. I also always set expectations for my patient. I let them know that we may not always be making eye contact because of the way the camera is positioned or the camera angle. I always make sure that I can hear the patient. I make sure that the patient can see me and that I can see them, and pay attention to how you're lit, how the patient's lit and mic'd. And then some checklist items for your note from here. Introduce yourself and verify the patient name. I'm not that much of a stickler, especially for well-established patients for this, but what I am a stickler for is knowing the exact location as much as I can of the patient and the person that I can contact during the particular visit we are having. That is always very important to me. And then finally, concurrent documentations and multiple streams of information. This is, I think, a job hazard within this medium. It is definitely doable, but for example, when I work on my ACT team, I have a secure messaging window open, I have the EMR open, I have a patient tracker open where team members write notes for the last week or last month of the patient's care. And there's just a lot of information hitting me. And of course, I have the video as well as the note that I'm writing. So there's just a lot to manage, but with a little bit of practice and having plenty of screen space, you can accommodate. And then specific populations. Focus mostly on primary care settings here. This is where most of our patients are and where most of the access is a problem. Like we said before, 40% of patients with mental illness are not receiving treatment. For example, collaborative care as a model is something that seems very exciting in terms of an intervention to help increase our reach to population health. Also incorporating asynchronous models of care. One thing as psychiatrists or caregivers in the mental health space, we always have to know what our impact and our presence will have on the team process, the dynamics, and the patient outcomes when we're inserting ourselves into a place that we're not normally in. Particularly within primary care, initially it was hard to convince the doctor that I might be of some use. After a little bit of convincing and seeing how they had more time to deal with the patient's chronic medical problems, the adaptation of psychiatric intervention within primary care settings holds a lot of promise. And then for each of the additional groups, for children and adolescents, it's nice to have toys, or there's even iPads that are on a robot that can make interacting with a screen a bit more fun. In rural settings, as in any setting, just be aware of the cultural sensitivities that you may need to have and varying than your own. And in inpatient and residential settings, geriatric settings, military, veteran, and federal settings, forensic and correctional settings, as well as substance use disorder treatment settings, they all have specific teams, they have specific cultures, they have specific models of care. And just like you would in person, be aware of them. One thing via telepsychiatry, you're not there in person, you're not there in 3 dimensions. So you have to make efforts to connect with people and to understand where they're coming from in order to be a useful caregiver. And there's just so much more we're going to be able to do. We may be able to predict suicidality or self-harm earlier using ecological momentary assessment, which in oversimplification is where a patient reports emotions either after an event that causes an emotional response or at a random prompt initiated by the tech. And then automated messaging, we've already seen that this helps with diabetes and hypertension management, and we're showing that it can also improve engagement in therapy. The next 2, asynchronous care and reaching refugees. Asynchronous care is where the patient and the provider are separated by time and space. For example, Dr. Hassan and Dr. Sharif's work has shown that patients living far away can present their symptoms, and then providers living halfway around the world can respond to those symptoms and give advice and hopefully facilitate improvement in health. It's just mind-blowing to me. Speaking of mind-blowing, the virtual reality, it's amazing to me how comfortable that we can feel with an avatar and how that can provide enough of a distance when dealing with trauma and give us enough space to be more vulnerable, to be more exposed. It's really hopeful to me that we're having these other ways of reaching patients. And the measurement-based care, psychiatry for too long has not had numbers, and I'm very excited to show people that we as a discipline can make people's lives better and approach wellness for our patients. So just in summary, thank you so much for the opportunity to talk to you a little bit about telepsychiatry and the implementation of this practice. It's a great time to be a psychiatrist. We're going to reach more people. We have better treatments, and hopefully we'll make it easier to be well. There's still a lot of challenges, but I'm supremely hopeful for the future. Thanks again for the opportunity.
Thank you, Dr. Qalbani, for that great talk, and thank you to the PsyQ community for listening today. That concludes this presentation. Have a great day.